And we'll begin. Right, welcome to the third event on mental health in children and adolescents, hosted by the Youth Resilience Unit at Queen Mary University of London. I am Dr. Caitlin Aspinall, the Research Program Manager of the unit. In today's one-hour workshop, Professor Bennett Leventhal will explore autism in children and adolescents and how teachers can best support these young people. While I'm compiling the questions for Professor Leventhal, one of our research assistants, Milena Nikolaeva, will briefly describe one of our studies that might be of interest to you. So introducing our speaker today is Professor Dennis Ugrin, who, along with Professor Jennifer Lau, co-directs the Youth Resilience Unit. And with that, I'll hand over to you, Dennis, and Bennett, you can share slides at any time.
Welcome, everybody. I just wanted to say that we are delighted so many people could make it, despite what I have to say is one of the days that's somewhat on the warm side. I must say I'm talking to you from my car because that's about the only cool place I could find. I hope people are well hydrated and could find some relatively cool places. Now, Professor Leventhal is a great supporter of our services in the UK, both research and clinical, and has been for many, many years. We have shared many warm days in London with him, and he's one of the best researchers and clinicians, especially in the field of autism, in the world. So we are very proud and delighted to welcome Bennett one more time. And with that, I will just hand over to him to start his talk about autism in school.
Thank you so much, Dennis. It's a pleasure and privilege to be here. As I was speaking earlier, some of you may have heard, I happen to be working this week in Paris, where it's even hotter than it is in London. That's not good for anybody and not much to boast about. But like Dennis, I hope you're staying cool and hydrated, and I suppose our hearts should go out to those people who don't have a cool place to go and who may be in jeopardy in these difficult times, both in the UK and throughout the world. I'm going to talk about autism spectrum disorders in school. I'm going to give a bit of a preamble about autism, but only because it relates to things we think about in schools. I have to tell you, I love working in schools. In fact, one of the reasons I'm in Paris is to do some work with a new innovative private school that's being developed here. But I think my most important working colleagues as a clinician, when I take care of individuals who have autism spectrum disorders, are teachers. And I greatly admire the effort you put in for my patients, and know that without you, both I and their parents would have no hope at all. And so anything I can do to help you in this process, both in the terms of this, both during the course of this talk, but even afterwards, if you want to communicate with me, I'm more than happy to chat with you and help in any way I can. I don't have any conflicts of interest that are relevant to this presentation, and so I'm going to launch right into it. So I think we have to remember that autism is one of a group of neurodevelopmental disorders. It's not, and it shares many things in common with these disorders. And indeed, many of the things that I talk about today might apply to a number of the other neurodevelopmental disorders. They're all syndromes. I'll explain that in a moment. All of them begin very early in life. So by the time the children come to you, they've had 2, 3, 4, 5 or more years of involvement with the disorder. It's arguable when they actually begin, but certainly, if not at birth, shortly after the time of birth. Whatever causes it, I'll talk about that in just a second, alters brain function largely related to social functioning, but possibly also language and cognitive functioning as well. It's usually a genetic disorder. I'll show you some information about that just to confirm that for you. It's often runs in families. Families share other things besides genetics. They share a common environment, etc. And so it may not always be heritable, which means that sometimes people with autism are the first to have the genetic mutation that causes their disorder. And there may be environmental factors I'll show you in a moment that may contribute as well, but all of them affect things early in life. This is the list of neurodevelopmental disorders, not for you to read, but for me to just remind you that it can also include intellectual disability, or what we used to call mental retardation, but also attention deficit hyperactivity disorder, ADHD, different kinds of movement and coordination disorders and language disorders, are all fit into this category. They're actually a group of neurodevelopmental disorders that others might consider to be neurodevelopmental disorders that don't fall in this category, but they're quite relevant to the discussion that we're having today. Obsessive compulsive disorder with symptoms that may overlap with ADHD, eating disorders, again, symptoms that may overlap with ADHD. Mood disorders are common associated with ASD. And then other disorders might seem unrelated, like substance abuse disorder, etc. And I put on this list Alzheimer's disease because there's actually some evidence that Alzheimer's disease is a neurodevelopmental disorder, with some of the signs, in some cases, appearing as early as late childhood or early adolescence. Want to talk about that later? We can, but it's not directly relevant. Hello? Yeah, not directly relevant to this talk today. So I want to remind you that ASD, or autism spectrum disorder, is one of this group of neurodevelopmental disorders. It's a syndrome. A syndrome is a group of symptoms that tend to cluster together and share a common natural history. This means that not everyone has all the same symptoms. Each individual can have a different combination of symptoms. That's very different from a disease for which which is really a syndrome that has a known cause or etiology or a known pathological process. That is, we know exactly what's causing it, something like an infection. But autism is really a syndrome. And it's not a very unusual type of illness that doctors deal with. In fact, most of the illnesses we deal with are syndromes. That includes things like diabetes, asthma, heart disease, etc. And it's confusing both for us, those of us who make diagnoses and study causes, but also for those of you who take care of these individuals, because it's very heterogeneous. All symptoms are not seen in all patients, and many of the symptoms are shared with other disorders. So that how do you sort out who it is important. And it means that the causes are complex. But remember, many of the interventions that we use are largely focused on symptoms and not necessarily on the syndrome itself. Now, many people have different ideas about what someone with autism looks like. It's been a very popular topic in the lay press, and everybody has a story to tell and presents a different picture of autism. It's even been in movies, and the people in those movies represent different elements of autism. And I'm sure you can think of a number of other movies as well. But the point is that not all of them are the same, and rarely are the people in the movies actually reflect the kind of character an individual with autism might have. So the term autism was given by a man named Leo Kanner in 1942. He came up with this in a description in a paper. He described 11 children, most of whom didn't have very good outcomes, and there's a complicated reason for that, but partly had to do with the nature of his referrals, and partly because almost all the individuals had coexisting intellectual disability or mental retardation. As I'll show you in a moment, that's not actually the standard story in our current understanding of the disorder. But it wasn't the first time that people with had ASD didn't appear in the 1940s. In fact, case reports of ASD or stories about people with autism go back thousands of years. This is a famous report on a young man named Victor, who was discovered by the French psychologist Itard in the late 1700s in the city of Aveyron. And he wrote a book about the wild boy of Aveyron, a child who was found wandering the forest near the town. And the lore at the time was that he was raised by wolves. It's certainly a model for causality, but not likely the true story. He was probably abandoned by his parents in the woods. In those days, parents could actually literally kill their children if they weren't healthy or weren't contributing to the family's well-being, this family may have thought they were being more kind by turning Victor loose in the forest. And in any event, Itard took him to Paris and trained him. And maybe the first good case report of a treatment of ASD. Victor never learned to speak, but he did learn how to dress and use proper Parisian manners as he went to dinner parties as a curiosity with Itard. So it was the first time that someone used structured behavioral management to train somebody with ASD. Now, we've been trying to understand the cause of ASD, and it appears that it's the most genetic of all disorders, amongst which we know there are multiple gene disorders. It's estimated to be 92% heritable, which is much more than things like blood pressure. ADHD is slightly less heritable, but I think that the important point is that this is largely a genetic disorder. It's not a disorder that you can catch by touching people or being with them. It's not caused by other kinds of events, with the slight possibility that that environmental factors play a role. And I'll show you a couple of those in a moment. But I think there's growing evidence that there's some disruption in brain functioning, whether it's how the brain processes certain kinds of information or whether structural damage to the brain is a matter of controversy, but it seems to go along with ASD. And I'll talk a little bit, mention something else about that in just a second. There are a bunch of perinatal risk factors that are associated with ASD, such as prenatal smoking, abnormal fetal position, having a lot of children, C-sections, but none of these, the risk factors, the risk ratios are really quite low and don't really point to a major direction in this area, except in a couple of instances where they're actually toxic exposures, like to heavy metals and things of that sort. One thing that definitely does not cause autism is vaccines. You know this story in England from Andrew Wakefield, the discredited gastroenterologist who published a series of papers about this a number of years ago. We now know for sure that not only do vaccines not cause autism, but they largely are protective of getting autism, because we know disorders like measles cause brain damage, and if you get a damaged brain, there's a risk of having autism symptoms. So it's important for all of us who are interested in helping children to make sure that they get vaccinated, because we don't want them to have an increased risk of other brain injury associated with these disorders. So one of the big concerns about autism is that the number of people who have it appeared to be rising. Or the increase in prevalence. There's an increase in prevalence. Well, why is this happening? Some people say, well, there must be something terrible happening in the environment that's causing it. That doesn't appear to be the case. And in fact, I'm going to show you some data from our work that's going to suggest to you that it's probably pretty stable, and it's something that teachers have probably known all along. By the way, most of these data, not from this slide and from others that people have reported, come from schools. And schools have certainly been having to serve a larger number of people with ASD, but just because they have to serve larger number doesn't mean that there are larger numbers. It just means the demand for their services is finally rising to the level that's appropriate. This is just another study showing the increasing prevalence of ASD, and it continues to grow even till now. Now, this is work that's important, not just because I participate in it, but because it tells us something really crucial about autism and what you're likely to see in schools. So this is a total population study in Korea where we screened about 65,000 children in schools in Korea. We did it in schools because all children in Korea must go to school. It's required by law. And with very few exceptions, children are there, 99%. And they're almost all in public schools because there are very few private schools in the country. And what we found is there are two groups. So the original prevalence, that is the number of children reported to have ASD, was 0.8% of the population. And what we found when we went into the schools and examined the children, and we separated them into two groups, one a clinical group and the other a non-clinical group. The clinical group was those who had been received previous services, whether it was special education, psychological services, or anything else. And as it turned out, about 0.7 or 0.8, in our study, 0.8% of the kids had previous clinical contact. But the total prevalence of autism was about 2.6%. And that meant 1.8% of that number of kids had never been evaluated by anybody, never gotten any special education or other services. Why was that? Well, as it turns out, in the clinical group, the large portion of children, this is using DSM-4 criteria, had autism, and they had significant impairment, and they more likely had cognitive impairment as well. That is, they had IQs, mean IQs of 75. Whereas the larger group of non-clinically involved children had IQs in the average range, which meant that probably most of these kids were functioning okay at a cognitive level, and they were just quietly sitting in school, maybe learning, maybe not learning, but weren't causing any problems. So 2/3 of the children who have autism are in school, involved in the community, whatever way they may be involved. They certainly have a dysfunction in that there are their scores on adaptive functioning and on other measures indicate difficulties, but they are just quietly participating in the educational and community processes. It's also important to note that it generally in the lower functioning individuals with ASD, the male to female ratio is 5-to-1. That is 5 boys for every girl. Whereas in the non-clinical population, it was only about 2 or 2.5-to-1. So we tend to see more girls who are higher functioning. Why this is a bit of a mystery. I could speculate on that, but I can't tell you. So what we know is that autism has developmental delays and developmental deviations with the impairment in a whole variety of areas that you know about. And that most kids get better over time. So and so it's important to have interventions. And now, given that we know the prevalence is about 2.6 to 2.7%, that means about 1 in 35 to 1 in 40 individuals in the community has autism. That would mean that we should logically expect that about 1 in every classroom of students, around 35 to 40 kids, would have one kid on average who has ASD. And they've been there, they've always been there, just no one has noticed them, or everybody noticed them, but just called them odd or quirky children, and everybody went about their business. And as we know more today about how to help them, these kids now are more likely to be identified. Now, part of the diagnostic problems we had with autism was that our diagnostic criteria were non-specific. And so we had all these other disorders, autism, Asperger's syndrome, PDD, a pervasive developmental disorder not otherwise specified, and there were other names. But it turns out when you use the old diagnostic criteria, we really couldn't distinguish them. They shared too many symptoms. And so as a result, the new diagnostic criteria only have autism spectrum disorder, which has 2 major sets of criteria: deficits in social communication and social interaction, and a set of unusual behaviors, restricted repetitive patterns of behaviors, interests, or activities. And that's the 2 main categories of symptoms that are a problem. And these lead to secondary symptoms like behavior disruption, et cetera, that may cause problems in the environment. And until recently, we weren't able to diagnose other disorders along with ASD, but we now know that there are many disorders that can co-occur with ASD, and those become a critical part of not only clinical work, but also working with them in schools, because we need to know that there are 2 things or 3 things going on at once. There's another condition called social communication disorder, which applies to a group of children who have the social communication component, but in theory don't have the restricted and repetitive behaviors. The validity of this particular diagnosis, some people question, and we tend to lump them into the ASD group when we think about them clinically. I'm just going to skip. The ICD has its own set of criteria. At the end of the day, I mean, we really think about it, there are a bunch of problems associated with ASD, but the ones that really account for functional difficulties, and when you face them in the classrooms, really fall on four main axes. One is cognitive functioning. The second is in the language, in the social skills area, how high or low your social skill functioning is, the level of language skills that you have, and then these odd behaviors, these restricted and repetitive behaviors. And so when we think about what we can do for children with autism, these largely are the symptoms we tend to focus on and the consequences of having these symptoms. There are lots of ways to assess children with autism. Hopefully by the time they get to you, they've had these assessments and you'll have information from them. If they haven't been done, then I think it's sometimes useful to think about what information you need in order to do your work in school. Things like adaptive functioning skills and understanding their cognitive level in particular. And there are many screening instruments that are available. All of these are useful. And sometimes it's very helpful for school to identify a particular screening instrument that they want to use, like the number 3 on this list, the autism screening spectrum screening questionnaire, or one of the others that are useful and sometimes helpful in providing clarity in school, even in the absence of a full clinical assessments. The gold standard for making the diagnosis is the autism observations, diagnostic observation scale, and the autism diagnostic interview. Ideally, we want every child to have this, but because it takes expertise and time, it's often not available, and we have to go ahead and do our work in the absence of the data from this. I want to make one comment about cognitive measures, because people with autism often don't do well on certain cognitive tests, and we get misinformation. So if you use the Wechsler IQ test, it's a highly language dependent test. And if you have language difficulties, which is common in autism, it may suppress your score. So if you get a Wechsler report, it probably is useful to look at nonverbal measures of functioning that'll give you a better sense of the child's capacity for cognitive work and cognitive processing. Understanding, of course, that anytime you become more language intensive in your work with the child, they're going to struggle a bit more. There are nonverbal cognitive assessments like the DAS, the differential ability scales. And if someone's provided you that, it'd probably give you a better assessment of what the child's actual cognitive abilities are. One of the other things that we like to focus on, and in classrooms in particular, is not cognitive level per se, but what someone's really adaptive functioning is. What can they really do with the cognitive abilities they have? By the way, this applies to all children. Many of us know very bright children who, have difficulty getting things done, and it's not just intelligence that plays a role in adaptive functioning. And in fact, one of our principal goals in training people with ASD, but also working in classrooms, is to increase adaptive functioning. And that may be a much more important goal for you as well. We have to pay attention to language, and it's always useful to have language measures. Which ones you get are not so important, but that you have some sense of what their language skills are. And then we have to remember that you may need other kinds of assessments. And the one I want to point out to you in particular is seizure assessments for seizures, particularly if kids seem to have episodes where they are not available. They seem to not just look like they're not paying attention a lot. About 25% of individuals with adolescence and young adulthood will have some kind of a seizure activity. And so if you're not sure they're zoning out, you may want to make sure that you get a referral to get that assessed, because it could be a problem that's easily managed. So once kids are assessed, what can be done in schools? Well, the tendency for most people is to think about what are all the problems. And there are a lot of problems, but there are also a lot of opportunities. Children with ASD can learn just like any other child, maybe not exactly the same way, but they can gain academic skills in almost every area. And in fact, because of some unique characteristics in an individual's cognitive function, can even excel or be precocious in a particular area, mathematics or reading or writing or other creative skills. So do not for a moment think that having ASD means that you're not going to learn or not going to learn at the pace or even a faster pace than other children in the class. School is also vitally important for children with ASD to help with social skill development. The best way to learn social skills is to be social, and in particular, be social with peers, and even more importantly, to have good peer models that you can imitate and who will work with you to develop social skills. In fact, this may be the most important thing that we do in schools with children. We certainly can improve language development because school is highly language dependent. And we tend to forget how important leisure and play is in schools. Many children will tell you their favorite part of school is recess or getting out in the end of the day when they can play with their friends. Sometimes helping children with ASD learn how to have leisure time and how to play both on their own and with peers may be a critical thing that they can learn at school. And then schools are part of a community, both their larger community within the school, but also embedded in the community in which the school exists. And having the children participate in community activities that schools, the school fair and things of that sort, are wonderful opportunities for children with autism. That doesn't take away from the problems that may occur in school, such as behavior problems, children being uncooperative or aggressive, difficulty communicating, problems with motivation, and then, of course, comorbidity. We'll talk a little bit about that in a second. So the addition of an ASD child to the classroom can be challenging or not, depending on how you approach it. So I always want to start from the position of if you're going to have, or if you do have a child in your class with ASD, the first thing to do is to make a plan and plan ahead. Don't try to do it on the fly. Know that find out from one source or another, whether it's in the school records or talking to a teacher who had the child before, or talking to the parents about the child's strengths and weaknesses. Our goal is always to build on strengths and try to work around weaknesses. If we can figure out what those weaknesses are, we try to develop a strategy to improve that functioning. But more importantly, we need to understand what that child needs at that point in time and try to meet those needs. It's always useful to know what has worked before and what has not. If things haven't worked before and you're confident that they've had a previously good trial, don't waste your time trying again. Use things that have worked before, and if there's nothing that's worked before, then you're going to have to start with something new. Working with parents is crucial in this because kids are in school only a short part of the day, a quarter of the day, 30% of the day, depending on the schedule. And parents reinforcing what you're doing in school can be vitally important to making sure that the things you're taught, both academically but also behaviorally, get sustained and repeated and practiced at home. And then it's really important if you're a teacher who has children with ASD in your classroom to develop supports. It's hard work, it's frustrating, and having other school staff, peers of your own to help support you when you have tough days is really crucial so you don't burn out. And finally, don't forget about student peers, having kids in the school who can help you. And I'll talk a little bit about that in a moment. So in the end of the day, it's really crucial that you create a plan and create reasonable expectations for what that child can achieve and what you can do to help that child achieve in the time that they're going to be with you and going forward. Some things work for all students, not just those with ASD. And so thinking about that in your classroom and how you set up your classroom to do that is probably really important. First of all, have an authoritative rather than authoritarian style of behavior management. Authoritative means you are operating from the position of superior knowledge rather than authoritarian, superior power. Power rarely works in struggles with most children. Being authoritative is often much more practical. establishing routines, schedules, and structures that are stable, predictable, and consistent over long periods of time helps all children learn, and it makes it much easier for a teacher to manage the classroom. So if things seem to be spinning out of control, it's probably better to have more routine and more structure than less routine and less structure. Whoever tells you that letting a child with ASD just follow their own course is probably not giving you good advice. Really use the structures that you know and can fall back on is always helpful. And identify reinforcers. What do I mean by reinforcers? Things that encourage someone to do the right thing. You do that with your own children. People do it with you. They pay you, and that reinforces you to go to work. So try to find positive reinforcers, things that encourage all of your children in school to do things better. For some of that, social reinforcers, but for positive opinions of them, and avoid negative reinforcers, punishment, humiliation, things of that sort, criticism, just tend not to work very well, and certainly not work very well in the long term. And one of the things I always remind people is about the basic behavioral management tool. The notion is that every behavioral sequence has three components: an antecedent, that is something that came before the behavior, undesired or desired, and then a consequence, something that happens as a result of that behavior. More often than not, we tend to focus on the consequence. So a child gets irritated, and then a child gets frustrated, then they hit someone, and then everybody gets all upset. And then you try to help everybody calm down. Our goal is to identify the antecedent and change the antecedent, shape the antecedent so that the behavior doesn't occur. Because if we pay too much attention to the consequence, we may tend to reinforce it and actually propel the individual along that behavioral sequence. So if you're starting to have trouble with a particular set of behavior in any child, stop and look, or have someone come and watch in your classroom to see what are the antecedents to the disruptive behavior, and see if you can shape the situation, change the antecedents, and then you won't see the behavior or the consequence. I know it's easier said than done, but it's important to remember this whole principle about looking for antecedents. And then there's a whole structured way of doing this called functional behavioral analysis. If you have access to behavior therapists or behavioral psychologists who can come into the school and actually do a formal assessment, that may be useful if the behavior is really, really disruptive. Social skills training is also an essential part of what we do with children with autism, and we can do it in any classroom. Any teacher can do it. There are certainly structured criteria, structured curricula for it that are benefit all children, but some of them are individual. Many of them work in group settings, and they have work groups, and we can teach of various kinds of skills to individuals. But creating social expectations in your classroom, not only for the child with ASD, but also for those without ASD, really enhances the environment for the child with ASD, because then they can start to have a structure and expect what they're supposed to do and how they do it. We find it particularly useful to create peer supports. That is, identify children either in the classroom or older children who are willing to be trained to assist the child with ASD in their social life, both in the classroom and throughout the school. Now, attendant to that is being able to develop a script or a talk so that you can explain to other children about what is ASD. And often we do that with parents of the child with ASD or the child with ASD themselves, so that everybody can come to think about autism as not a curse or not something that makes it bad for somebody, but as each of us has our abilities and lack of abilities. And for someone with ASD, they often have difficulty with social interactions, and if we can pay attention to that and try to help them rather than think of it just being weird, then it removes some of the stigma and makes it easier for everybody to work together. I could tell you hundreds of stories, and if you ask later, I'll tell you some about how sensitive kids are to their peers with ASD, once you explain to the typically developing children what is ASD and how it interferes with their peers' functioning. The kids are amazingly good at being social supports and even good social therapists without any formal training. Parent buddies are also useful, helping parents find other parents to support them in dealing with the school and dealing with the stresses of having their child in school. And then making sure, even though the kids with ASD may have difficulties with this, that they engage in leisure and play activities such as athletics, music, theater, crafts, arts, whatever it is, because those are non-academic social environments where some of these kids can excel or at least have fun and have fun with their peers. And that gives them at least some positive elements associated with school, but may even find skills that they find rewarding and interesting. Now, many children have difficulty finding motivation in school. Most kids in your class will find pleasing you as a teacher as a positive motivator, but social motivation may not work or be as meaningful for children with ASD, partly because they have difficulty perceiving it. They have difficulty with subtle facial expressions and subtle vocal expressions, and so it may not work. And grades may not be motivating either. So one of the things that's really important is to quickly identify targets that lead that motivate the child to continue to do certain things in schools. And some of them may be a bit unusual. So finding out from the family what is motivating and previous teachers have found motivating, it will be extremely helpful, so that when you say to a child, instead of saying to a child, make me happy or make me proud of you, you say, if you can complete this task in 10 minutes, it'll be outstanding. And they may be very good at working within a time frame and be very pleased that it ends on time. But there are other kinds of motivators that you can find. In some cases, the reinforcers, the things that encourage behavior and things that motivate functioning may be the same. And you may just have to have that list available to you. I mentioned comorbidity or coexisting conditions before. If you're having trouble with a child with ASD who otherwise you seem to be managing well, if there's evidence of some other condition, medical condition or psychiatric condition like ADHD, anxiety, depression, or OCD, for example, you need to get those treated as well. And they may or may not be amenable to interventions in schools. So don't wait. Get that taken care of early if you have evidence that exists. I want to make just one quick plea about bullying. Bullying is very common, and it's often unseen by teachers unless they're really looking carefully in particular places and at particular times. It's estimated that between 40 and 50% of all children are involved in bullying. I know that seems like a staggering number, but there are many, many, many studies that now support that. And there are many roles that people play in bullying, and children with disabilities are much more likely to be involved in bullying. Now, children with it, there are multiple roles. You can be a perpetrator, a victim and a perpetrator, a passive observer, that is, you watch and don't say anything, or an active observer, you watch and occasionally encourage or discourage the bullying. Children with ASD are more likely to be victims or perpetrators or victim perpetrators. When we look at studies, we often find that, and we've done some work in this area, that children with ASD may be mistaken as perpetrators when in fact they're victims who are reacting or being socially inappropriate, and makes it look like they're perpetrators. But nonetheless, they are involved in bullying, and bullying is harmful, has many serious adverse consequences, including increased risks of suicidality, increasing risks of depression, and we want to stop it. Stopping bullying, as you probably know very well, is a community solution, not an individual child solution. It takes groups of kids and groups of teachers working together to address it. But when you have children with ASD in your classroom, you really need to be looking for bullying as playing a role in their lives. There are other challenges that people often don't think about for children with ASD: suicidality. They get depressed, they get sad, they get frustrated and have suicidal ideation and occasionally suicidal attempts. And this is even in younger children, school-age children, not just adolescents. The whole issue of sexuality is particularly complex for children with ASD. Understanding sexual roles, understanding pubertal development, managing pubertal development is often a very vexing challenge and takes a great deal of preparation. And for typically developing children, can be especially complex for children with ASD. And having a plan and working closely with parents and peers to address this is important. We're also seeing tremendous problems with social media. I'm sure you see it in general with kids, but children with ASD often don't understand what's happening in social media. They can be bullied during social media and can be sexually exploited through social media. And we have to be very, very careful and monitor that with the parents. And then the last thing that often gets lost is many schools have wonderful teachers, wonderful services, and do great. But when children finish secondary school, it's called falling off the ledge. There are often no services in the community. And so as kids get into high school, 15, 16, 17 years of age, we need to begin planning then, not waiting until they're 18 and they're graduating, for what's going to happen when they finish with school. Many can go on to college or technical schools, but making a plan, because they may need assisted programs, will be really important, and we should be doing that as well. So what are the outcomes? Most children with ASD get better over time. Most of their symptoms get less, and mostly they learn things, particularly in school. They learn social skills, etc. Children who have higher level of functioning, and we mean higher functioning, they have higher adaptive functioning skills. They can live independently or semi-independently. Most have jobs and careers, and many have social lives. They may be somewhat unique in their social lives, but nonetheless, they have social lives. And occasionally they marry and even have children. So, I think it's important to find out what their ambitions are and try to help them meet their goals and ambitions, just like we do with other children. So in the end, education, your job as an educator is not only to help the children find joy in learning and being in school, but also prepare them for success in adult life, just as we do for all children. And while their potential may be slightly different, it's not terribly different. And you as teachers play a crucial role in that future. With that, I will stop. I think we have about 15 or 20 minutes, and I'm more than happy to answer any questions you might have. Thank you.
Thank you so much, Bennett. If anyone has a question, please put it into the chat. Comments are welcome as well. While I'm compiling those questions and comments to read out, Elena will now take 5 minutes to tell you about a study that might be of interest to you, and then we'll come to the questions. So you can share your slides at any time, Elena.
Thank you very much, Caitlin, and thank you so much to Bennett for such a wonderful talk. Do let me know if you can see the slides. I'm sharing them now.
Yep.
Perfect. So I'm just going to briefly tell you about a brand new study that we're launching within the Youth Resilience Unit, and it is called the DEAR study, which stands for the Development of Emotional Resilience. So before I give you a brief overview of what the study is about, I'm just going to quickly talk to you about resilience itself and why we want to look into it. So resilience is quite a dynamic process. It's plastic, modifiable, which means it's not something you're stuck with for life in terms of you can develop this skill set. And that's really good, especially with children, because we can look into building the skill set within children to help them transition into adolescence and adulthood later in life. And there's lots of different factors that influence resilience, both things like individual factors, which may be personality, perseverance, but also external factors such as community resources and their immediate surroundings. So why study resilience? Well, there's been lots of research done on teenagers and young adults, but not a lot is known about resilience in younger pre-adolescent children. And this is an earlier stage of development where resilience is beginning to develop and emerge. And we want to look into East London in particular, because this area is historically underrepresented in research around mental health and in particular resilience. So within the Youth Resilience Unit, our aims are to better understand what preventing or overcoming mental distress means to children, how resilience develops and changes over time, and see what kind of factors are important for developing resilience in children. So things like personal traits, social relationships, and external resources. and how these work together to then impact the growth and development of resilience in children. So we'll be focusing on individual factors, community resources, and we'll be using these findings to pilot community-based interventions to try and boost resilience within children. So how will the DIS study run? We are funded by the Barts charity for 5 years, and our plan is to visit primary schools in East London twice a year, and we'll be recruiting children from years 3, 4, and 5. Children will be completing activities and questionnaires related to resilience, and we'll be looking at a broad range of factors from mental health, so anxiety, depression symptoms, PTSD symptoms, but also things like relationships, spirituality, and things like that. Parents and teachers will also complete some short online questionnaires relating to the children's strengths and difficulties, their social network size, but also things about their socioeconomic status, demographics, diet, and so on. And there's lots of things that we can offer to schools in return as well. One of the big things we're hoping to do is to help schools plan a whole school approach for mental health. And this will hopefully support both pupils and staff with learning more about mental health, devising strategies in order to improve the mental health of pupils and to create a better environment for them, and also stimulating conversations about mental health. We would also like to use the data we collect to help schools identify their areas of need. So perhaps some children may be overlooked and struggling, and the data we would collect would go directly to the schools as well, so that they would be able to understand and learn a little bit more about what it is that the students may be struggling with. And also we would be offering some workshop and school trip opportunities, which would be a massive plus to the students via dedicated public engagement officers. And this is just a small slide showing an example of one of the recent workshops we ran with children. It was about 15 different children, and we were accompanied by an illustrator called Ali Wynn. And essentially, we ran a workshop to stimulate conversations about mental health and run lots of enriching creative activities with the children to boost their knowledge on mental health, find out what it is that makes their mental health more positive, and things like that. So this is something that, again, we would be able to work with the schools to do and hopefully work together with the pupils to deliver those workshops. So yeah, that was a very short sort of presentation about the study. If you are interested in taking part, do contact us. I've linked the email and Twitter on the screen there. And I'm sure some of these details can be passed on to you if you are a primary school residing in East London. And a massive big thank you from the Youth Resilience Unit, and a very, very big thank you to Bennett as well for giving the talk today, giving up your time. And thank you everyone.